Good morning. This is Lori Myers, the training coordinator with the Department of Developmental Disabilities. I would like to welcome everyone to the webinar this morning on diagnosis of autism in very young children. We have some content experts with us from Nationwide Children's Hospital. We have Dr. Christine Eichelberger and Dr. Elizabeth Kryzak. Christine Eichelberger, PhD, BCBA, D, COBA, is a psychologist and board-certified behavior analyst at the Nationwide Children's Hospital Center for Autism Spectrum Disorders. She's also an adjunct assistant professor in the Department of Pediatrics at The Ohio State University. She is responsible for supervision and training in the Early Intensive Behavioral Intervention Program. In addition, she's responsible for providing assessments, behavioral consultation services, and parent training services. Her clinical interests include treatment outcomes for young children with autism receiving intensive behavioral intervention, as well as the treatment of feeding issues in young children with autism. Dr. Eichelberger is a graduate of the doctoral program in MRDD psychology at The Ohio State University. Elizabeth Kryzak, PhD, is a psychologist at the Nationwide Children's Hospital Child Development Center. She's also a clinical assistant professor in the Department of Pediatrics at The Ohio State University. Dr. Kryzak's primary responsibilities include evaluation and diagnosis of children with ASD and other neurodevelopmental disorders through both interdisciplinary diagnostic assessments and psychological evaluations, along with providing some behavior therapy focused on building skills and decreasing problematic behavior in this population. She also participates in the CDC's large clinical training program and is the director of postdoctoral training. Her clinical and research interests primarily focus on early identification and treatment of young children with ASD, and she's currently the primary investigator on a study using eye tracking and Lena recording technology to track early treatment outcomes. Dr. Kryzak is a graduate of the doctoral program in clinical psychology at Bowling Green State University. So with that, I'm going to turn it over to Christine and Liz.
Good morning, everybody. Thank you very much for inviting us to come talk with you today. We were asked to come speak specifically on assessment for very young children with autism. I mean, many of the kids that you would be seeing in the Help Me Grow program. And our goal is really today would be to describe the referral and diagnostic process for these very young children so that providers can better support families prior to, during, and after their evaluations. We also wanted to discuss signs and symptoms of autism in younger children that you might be looking for as these children are being referred into Help Me Grow and their initial evaluations are being conducted for eligibility. But thought it would be helpful first to discuss a little bit about the program that we work for, the Nationwide Children's Hospital Autism Center, and our role, the services and the roles that our roles in it. So basically, Nationwide Children's Hospital, the Center for Child Development and the Center for Autism Spectrum Disorders fall under the larger behavioral health umbrella. The Child Development Center is primarily responsible for doing assessments and diagnosis, while the CASD is primarily responsible for treatment and intervention. So I know sometimes that is not always clear. It's often called the Autism Center, and people don't always realize that there's two separate components to it that work together. So part of the Autism Center does assessments and diagnosis. The other part is doing treatment and intervention, and then we kind of coordinate and collaborate together on that. So within that behavioral health umbrella, the CDC and the CASD are part of the academic division at Ohio State. It's part of Developmental and Behavioral Pediatrics. So at the CDC, their appointments often involve the interdisciplinary teams, and so they have close ties between psychology, psychiatry, pediatrics, speech therapy, While at the CASD, our clients are already in treatment, so we do a lot of collaboration with speech, OT, PT, the pediatrics and medical providers, daycare, school districts, the county boards of ED, and Help Me Grow. So there is a lot of collaboration both within the hospital and outside the hospital with different medical departments as well as other agencies that work with these children. So just so everybody knows, our offices are located in Westerville. Back in 2005, the hospital moved all of the services for autism into one building. Located in Westerville, and that has since expanded several times. The first expansion, the Child Development Center moved, we added a whole back wing on to increase the developmental and behavioral pediatrics. Then they added a side wing on, which was for psychiatry. More recently, our outpatient counseling program has moved downtown to Broad Street. And the CDC has moved some of their clinics down to the new Livingston Avenue Center. And we are currently in the process of expanding to the lower floor of the building. The behavioral intervention services are moving downstairs so that the upstairs portion can be completely devoted to complex behavior and basically a day treatment program for children with more severe and challenging behaviors. So as the population of autism has increased, the services have increased tremendously, and we just kind of keep expanding and expanding and expanding. So, sorry, went too far. So our roles are a little bit different. Liz is involved in the CDC and is really involved with the diagnosis and assessment. I am involved with the CASD and primarily involved with the treatment intervention. So I'm going to let her take over and talk a little bit about the CDC and the assessments and evaluation process that happens there.
Hello. So I'm going to talk with you guys a little bit first about the broader CDC in general, just because we do more than just autism. So I want to be able to give you a full range of what our services are, just because we can help lots of different children that you guys will likely see within your work. So just to give you a little overview of who is at the CDC, we have a lot of different types of professionals that work with us. So lots of psychologists. So right now we have 21 psychologists, a lot of psychology trainees. We also have a lot of other specialties, so many medical specialties that work with children with autism and other developmental disabilities, as well as speech therapy, social workers. And we also have a pretty decent research department as well within our program. So we have so many people because we see a lot of patients. So we see for the main autism assessments we do right now, we're up to 33 per week, although we're always trying to add more. And then I'll talk about all of these different services as I'm going through each one of them, but mostly this slide is in here to let you know that we're trying to see as many families as we can throughout our different services that we have here. Yes, we see about 12,000 annual visits per year. So just to give you an idea of the amount of kids that we're trying to see per year. And this is also just a slide to show you some of the different services we have. So I'm not going to be going through each one of these different services, but we are involved in a lot of clinics throughout the hospital, not just for autism spectrum disorder, but for other medical conditions that often involve developmental disabilities, such as different genetic conditions or medical conditions. We also just have different treatment clinics as well that I will touch on a little bit later. And then we're involved in other clinics outside of the hospital, including 2 rural outreach clinics. We're also involved with a home for people with more significant developmental disabilities, both children and adults. That would be the Heinzerling Foundation, as well as one clinic all the way in Brazil. So as I was saying, with the CDC, don't just think autism. So we service families with a range of developmental concerns, including intellectual disabilities, global developmental delays. We see children with different genetic syndromes. And basically what we're trying to do at our center is we tend to get families whenever the hospital is concerned about any sort of developmental delay. They typically come to our center first for some initial diagnoses or evaluation to try to understand those developmental delays. So this is a flow chart that helps describe what families or how families typically move through our system. So all families who come to the CDC will start with a diagnostic interview. And so I'll be describing each of these services a little bit more in detail as we go through, at least for the pathway for autism. But the goal for that first initial diagnostic interview is to figure out what is the most appropriate pathway through our system for families. Children where the main concern is autism spectrum disorder will primarily be referred to interdisciplinary diagnostic assessments, which again I'll describe in more detail as we go on. And then once those families go through that assessment, they'll be coming back for the last step, which is going to be a feedback with us to talk about connecting with additional services. And so then they'll go on to other services within the hospital, other community providers, Help Me Grow, as well as other services like speech or OT. But since we don't just service children with autism spectrum disorder, we also have other service lines throughout the CDC. So for children where the concern isn't autism, but other neurodevelopmental conditions, we have psychological testing within our center, or we might refer to other clinics within the hospital for additional assessment or services. And then for children where the concern isn't developmental disabilities, but other mental health issues, we'll refer to other clinics within the hospital. So we have our early child mental health program, which is where therapists are working one-on-one with families. And then we also have Incredible Years, which is where families are going through a parent training program for more significant behavior problems in younger children, or we'll refer to other non-hospital services as needed for the families, depending on where they're located or what kinds of services they need. So before they get to that initial DI, though, we need to get them into the hospital system to begin with. So that's going to start with a phone call with our behavioral health intake services. So right now, the majority of the referrals we receive are going to be placed either online by the child's pediatrician or another medical specialty. And then our behavioral health intake will call the family. So we have a link online where pediatricians can place initial referrals. As of right now, there's no way for Help Me Grow providers to directly place a referral, but they can either talk with the family about talking with their pediatrician or connect with that pediatrician directly. Families are also able to just initiate the process on their own. So Help Me Grow providers can call with the families. That's our intake number there, the 614-355-8080. And basically when they call that number, or if intake calls them, the point of that is going to be to gather just some initial background information on the presenting problems or concerns and get the family connected with the most appropriate place. So if that referral is specifically focused on concerns for autism spectrum disorder or other developmental delays, families are most likely going to be scheduled with a DI within the Child Development Center. If there's other mental health concerns or other treatment needs, behavioral health intake will direct the family to whatever service is going to be most appropriate and get them scheduled for that. So we're going to start with the DI. So going back to that kind of step-by-step process, once families are referred to us, they're going to go to that initial diagnostic interview. And that's really our service to help us make sure families are going to the right evaluation. And the point of that is that we want to make sure that families aren't going through any evaluation unnecessarily or wasting any additional time unnecessarily, as well as to make sure that we're most effectively putting families in different evaluation tracks so that we're not unnecessarily ballooning some of our wait lists. So really our goal with this is to figure out what the families need. And so that's going to involve a 45 to 60-minute interview. And that's going to be with the caregiver, but we also want to be able to see the child during that appointment. So children are usually playing with some toys or interacting near, so that way the diagnostic clinician can watch and observe that child and see any additional behaviors that might be helpful in directing that child where they need to go. And so that initial diagnostic interview is not only going to involve the collection of historical information, but we also have families fill out a child behavior checklist, which is just a general behavior rating form that allows us to look at a lot of different problem areas that kids this age can have difficulties. And then we're also just going to look at broad records, any available records that families bring in of additional assessments or medical records that are available. And the most important thing to keep in mind with this visit is that we won't be giving a final diagnosis here. Sometimes DI clinicians are ruling out autism, so if they really don't think it is autism, they may say that at this initial visit. But really, the point of this is to help them get to the next step. There isn't going to be any psychological testing that's happening during this visit. So this is one of those things that's really important to stress with families, just because a lot of families come in thinking they're going to be getting the full diagnosis that day. But this initial appointment is really just to make sure they're getting to the right evaluation appointment next. So when we're thinking about who to refer for a DI, as I was saying, you don't have to just think autism. So that's probably the most common reason families are coming in. But really, any neurodevelopmental delay or developmental problem, families will get referred to us for many different developmental issues so that we can do a more broad assessment with them or get them connected with treatment services. Right now, we see a pretty broad range of families, starting with children as young as about 12 months old, all the way up to young adults. And we're Help Me Grow, we often see kids that not just with concerns for autism, but other multiple disabilities. So children with motor delays or children with other medical concerns like epilepsy, cerebral palsy, or other genetic conditions, because autism often can be there with those different conditions. So actually one of the earliest signs of autism can actually be motor delays. And so oftentimes those families are connected with you guys first to begin addressing those early motor delays, and then are often come to us as those delays continue. And then we also see other delays like the speech and social delays starting to come or become more apparent. And then we see families from all over both the state of Ohio, as well as we see a lot of families from West Virginia and Kentucky. We see families from across the country, and we've even seen a couple of international families for diagnoses in lots of different areas. Be a pretty broad population. I'll switch back to you now.
Okay, and if there are any questions so far, feel free to type them in. We can take them kind of as we go, or we'll stop at the end for questions too. But at this point, thought it would be helpful as we're getting to the diagnosis, just to give a little information on autism and what essentially we'd be looking for in that initial diagnosis, and what you might be looking for as far as early signs, what autism might look like in a young child. So right now, from the Center for Disease Control, about 1 in 59 children has been identified as having an autism spectrum disorder. So it has been a rapid increase. I'm going to show you a graph in a minute. But autism is reported to occur equally in all racial, ethnic, socioeconomic groups. Autism doesn't discriminate. And it's about 4 times more common among boys than girls. So just as some general information. And this is some prevalence information starting from the 70s and 80s up till some of the more recent from like 2014 and 16. And they say for boys, it's actually about 1 in 39 right now, I think is the estimate when you're specifically looking at boys. So obviously, you're seeing more of these kids. We're seeing a lot more of these kids. This is why our services have expanded so broadly, because of the number of diagnostic appointments that are being referred to us. So, early signs of autism. Autism, just so people know, autism can be diagnosed as young as 12 months old. And they have seen a few kids here who did come in. I had a little girl that came in at 14 months that have been diagnosed at 12 months. Liz has seen a 12-month-old. So it can be diagnosed as young as 12 months. That's more rare. Most professionals won't make a definitive diagnosis until 18 months. Some of that is due to one of the diagnostic measures, the ADOS, you really can't administer until the child has a developmental level of around 12 months. So even giving an ADOS at that point is still, it's not always accurate. So by about 18 months, things are starting to become a little more clear, and clinicians start to feel a little more confident in terms of making a diagnosis. And then the most obvious signs may not occur until between ages 2 and 3. And I know just from clinical experience, a lot of the repetitive and self-stimulatory behaviors might not really even start to ramp up until closer to 3. So I would say it's more common by the time kids, they see their pediatrician between 18 months and 24 months, they get a referral, they come in, there might be between 2 and 2.5 when they get diagnosed, and then closer to 2.5 or 3 by the time services are set up, is probably the more traditional that we're seeing. Some parents may notice signs in infancy or, about 9 to 12 months as a child. Maybe some of those motor milestones aren't being met. The speech milestones are not kind of falling in place like they should be. So some parents definitely have concerns. We see a lot of kids that have had like extreme prematurity or other sorts of medical issues going on, and there's been concern from the very beginning. However, other kids seem to develop typically until they're 15 or 18 months old, and then they start to show a very clear regression. So that I know that that's very hard on families when they have that typically developing child who then suddenly starts to lose skills. Just last week, I had an intake appointment with a sibling, one of my clients. I had seen the sibling like 5 months ago. Sibling was totally fine. She was 10, 11 months old at that time, looked absolutely perfectly typical. When she came in last week, and this was only 5-month difference, she was a completely different child. I mean, she had lost all eye contact. She wasn't socially interacting. Her facial expressions were completely flat. She was totally different. So sometimes a lot of times there can be that regression that starts to happen that between that 15 and 18 months time frame. So that's why they ask pediatricians to complete the MCHAT screening. It's a modified checklist for autism in toddlers. It's highly recommended, and there's lots of first steps programs and all that where pediatricians are supposed to do that basically one-page screening with families at the 18-month checkup that looks for red flags. So basically just a list of quick questions that they go through with the family. We put the link on here. I'm going to open it up just to show you some of the questions. Hopefully that'll work. Okay. But that is a link to the MCHAT, and it sings about eye contact and responding to smiles and pretend play and just this basically a yes no. And if they get a certain number of red flags on that checklist, and the pediatrician is supposed to refer the child on for a more detailed evaluation. And that is because early diagnosis and treatment is the key to successful management of autism. So the goal is to get kids in as early as possible, even at 18, 20 months, for an evaluation so that they can be set up with treatment services. So in terms of early signs, what we're looking for in a 15, 18, 20-month-old, basically a language delay, that their language either regressed, maybe they had some single words that they're no longer saying, but basically they're not attempting to communicate, maybe very limited babbling, they're not directing their babbling or their words, they're not directing those to people. They're not using gestures to try to get their point across. They may not be pointing at objects to request things or to show interest. They may be slow to smile or show happy expressions, so that they may not smile back in response to somebody else. So that kind of flat affect. Goes along with the poor eye contact during social interactions. So they may not respond to their names or respond to a familiar voice when somebody walks in the room. Can be difficult to get and keep the child's attention. So they kind of seem like they're in their own world, and they might even be totally content to play them by themselves for long periods of time. They don't need other people, essentially. So they appear to ignore and not hear others or not be aware of others around them. And they are aware of them, they're just not interacting or engaging. It's not of interest to them. And they may not have a reaction if others are upset or hurt. They may not even, like I said, be aware that somebody walked in the room or that somebody dropped something, or they're just not really concerned about what other people are doing. They may not be initiating or accepting affection. So they're not reaching to be picked up. They may cry or resist when their parents try to cuddle them or touch them. So some of that sensitivity to touch might be a sign as well. So those are some of the social delays. Also see deficits in play skills. So they're not initiating social interaction. So they're not giving items to people or trying to share items, show items to people. Very limited joint attention. So they may not be following. If you point to something, they may not follow your point to see what you're showing them. They may not follow your eye gaze to see what you're looking at. They're not sharing enjoyment in an interaction with somebody. They're not playing those little social games back and forth just because it's fun to interact with somebody, like the peekaboo and chase and things like that. They may not just really get a whole lot of enjoyment that they're sharing with somebody. A lot of repetitive play. And this is, repetitive play is pretty common for an 18-month-old. A lot of 18-month-olds are putting things in and out of containers, and they're doing a puzzle over and over again until they figure it out. But what you see is with these children is the repetitive play to the exclusion of doing other things, or where it's interfering with them being able to interact with people or interact with other toys. So they're so focused, or they will only do certain things that they won't play with other toys or figure out how to do other things. So lining items, stacking items, moving things from place to place, putting things in and out of containers, visually inspecting objects, just rolling things back and forth in front of their eyes. So what you really want to look at is how easy is it to interrupt or change their activity? Do they get really upset if you try to interrupt their play, if you try to play with them, if you try to do things differently, if you try to show them a different way to play with something? Can you teach them how to play with something versus are they just going to go back to rolling the train back and forth in front of their eyes? They usually have pretty limited functional play skills and very limited pretend play or imaginative play. So by 18 months, most kids are starting to pretend. They're starting to feed their animals or their dolls, or pretending to talk on the phone. Our kids, the kids who have suspicions of autism, may not be doing that. And they're not imitating others. So they're not, part of the reason that they're not playing or picking up on these play skills is they're not watching others, attending to them, and trying to imitate what other people are doing. So that lack of imitation is a core deficit that you'll see. And at 18 months or 20 months, that's imitation during play, that they're not imitating like play activities and play movements. You'll also see some unusual behaviors. So maybe some repetitive movements, the hand flapping, toe walking, finger posturing, body tensing, rocking back and forth. Repetitive speech or sounds that are especially not directed towards other people. So I think we had joked that one of the most common sounds you'll hear out in our waiting room is a dugga 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 dugga. It's just that kind of making a repetitive sound, or a kind of screeching noise, or just basically vocalizing that's not used to communicate. It's just used not functionally. They might get rigid, so they need activities to happen in certain ways. They get easily upset or overly upset if toys don't work right. They may need to sit in a certain seat or drink out of a specific cup, or have a carry around toys in their hand, and they won't put things down. So anything where you see routines that can't be interrupted. May have sensory sensitivity, so to sounds or to clothing or to textures. Some of the self-help things like getting their hair cut or nails clipped or teeth brushed. Even the sensitivities to some of the just physical touch. They may have unusual interests, so things that other kids might not be interested in, like wheels and fans and cords and pencils and hangers. They may stare at lights or look at things out of the corner of their eyes, run back and forth, pace and patterns across the room, looking at things out of the corner of their eyes. And then frequent tantrums. And again, 18, 20, 24-month-olds are going to tantrum. That's why terrible twos, there's going to be lots of tantrums. A lot of times you'll see the tantrums in the kids with autism just because of these rigidities or these changes. These minor changes that they should be able to kind of get through and get over, that they're not. So one of the big signs is any regression. So if they were saying their first word but stopped, if they kind of lost some of their eye contact, they stopped responding to smiles, they stopped playing with toys, they stopped socially engaging, that's a huge, huge, huge red flag. We also want people to be extra kind of watchful and extra vigilant if the child happens to have a sibling with autism. So many of our kids that we work with do have siblings, and we keep a close eye on those siblings during this time period to make sure that they aren't regressing and aren't starting to show some of these same signs. So I'd say if you are seeing a child that has a sibling, if you're seeing any of the things that we mentioned, it would be even more of a concern if they have a family history. So we did want to show this video. It's by the Kennedy Krieger to the Center for Autism and Related Disorders, and it's a nice video kind of demonstrating some of the early signs of autism in comparison to a kind of typically developing child of the same age.
Christine, sorry to interrupt. The sound is not playing on the video. Is there a way to turn up the volume, maybe?
that any better, Stacy?
Not yet.
Oh, sorry.
Oh, that's okay. I'm listed as Stacy on the. Yeah, maybe can you try starting the video from the beginning again and see what happens? Still not playing the sound for some reason.
Okay.
Luckily, though, you can decipher what's going on based on the teletype in the video. So
True.
Video is very widely, like you can just go on YouTube and search Kennedy Krieger Institute Autism videos. So
Okay.
participants can definitely watch it at their own time.
Okay, sorry about that. Let's go back to, there we go. So it's Early Signs of ASD video by Kennedy Krieger, and it is on YouTube, so it's very easy to find on there. And it does compare very young children, but with ASD and without, to kind of show the difference of what those kids kind of would look like. So basically, when would you, so you're seeing, you know what to look for now. You see all those, some of those signs of autism. So when would you, at what point would you decide you need to make a referral? So you're going to look for patterns, obviously. The more signs you see, the higher concern there is. And so the more need to make a referral. So the more of those pieces that you're seeing. And if you're not sure, just make a referral. What's most important is to get the child in. Early identification is the key. And it's never too young to have just a general developmental evaluation. And that DEI process is a screening, and that's what's going to determine if a full diagnostic evaluation for autism is needed. The family may have that DI appointment and the clinician may say, no, there's no need for any further assessment. So it's better to be safe and have them go through the screening process and kind of see what comes of that. And there is not a minimum age. Like we said, the pediatrician should be screening at about 18 months, but the youngest the CDC have seen is 12 months, as we've said before. So you could send kids in specifically for developmental screening, even as young as that. But the earlier, the better.
I'm going to switch back over and start talking a little bit about the actual diagnostic process itself. So we've talked about that initial DI, and so after the DI refers to an interdisciplinary assessment, or what we call an IDA, I want to talk about what that's going to look like. And so this is a two-part assessment. It's a multi or interdisciplinary assessment, meaning that there is multiple people part of that diagnostic team. And so it's the first day you're actually going to do that team part of the evaluation, where you'll meet with someone from medical specialties. So that could be a developmental pediatrician, a nurse practitioner who specializes in development, or a neurologist who specializes in development. There'll also be a psychology piece to that team, and so that's either going to be a psychologist or a psychology trainee who's being supervised by one of our psychologists. And then there'll be a speech language pathologist as part of the team. And then we also have a genetic counselor that meets with many of our families as well. And then the second part of that assessment is going to be more to characterize the different developmental delays. So we'll do more of a psychological assessment where we're really looking at different areas of development, both through direct assessment, which I'll talk about, as well as parental assessment or parental report. And that second day also just gives us a second time to see the child, interact with the child. So particularly for our trickier cases, it's just nice to have that second observation, as well as because we're doing more structured tasks, it often gives us some insight as far as what would be helpful regarding behavioral intervention. So a lot of times we are seeing a lot of the behavior problems that our kids may be having, like temper tantrums or difficulties with changes, and we can start doing some intervention actually as part of the assessment to see what might be helpful. Then after that assessment piece is finished, we'll have a clinical feedback session where the psychology team member is going to meet with the family one last time to review final recommendations, diagnostic impressions, and then recommendations, and then the parents will also get the diagnostic report. So I just want to be able to go in further detail as far as what those assessment days look like, just because you guys probably get a lot of questions from parents when you're referring as far as what the assessment will actually look like. And so for that first IDA day, we typically are going to be seeing the family for about 2 hours. And as I said, that day, they're going to be meeting with multiple team members. The psychologist and the medical provider, their main goal that day is going to be to do a pretty in-depth interview with the caregivers. We don't want to start from scratch, so we do have all that information from the DI that we review with families to make sure it's correct, as well as we may have other documents from other providers, such as school evaluations, Help Me Grow evaluation, other medical information. And then our job is to just ask further questions to get a more in-depth history. So we ask a lot about prenatal and medical history. We're going to look at developmental milestones, other symptoms of ASD that weren't touched on in that initial DI, as well as we want to know about what else is concerning the family. So a lot of our kids are having some pretty significant tantrums that may include aggression or self-injury. A lot of our kids also have safety concerns. So they may be kids that either try to run off or try to get out of the house, climb high places if not carefully watched, try to get into things they're not supposed to, as well as concerns with things like sleeping, eating, toileting. Those are probably the 3 areas we hear the most concerns for families when they're concerned about autism, as well as what are their current self-care abilities, and then ask them a little bit about current services, just so we can understand what the family's already receiving to help shape our recommendations. And then during that same visit, a psychometrician, which is like a psychology assistant that specializes in completing psychological testing and scoring that psychological testing, while the psychologist will actually do the interpretation of the results of that testing. The psychometrician will complete the ADOS with both the child and caregiver present. So that ADOS is the Autism Diagnostic Observation Scale, and that's basically a play-based assessment. And what it does is it puts the child in a lot of different play and social situations. So like there's like a free play with a bunch of toys. They'll also do like a little birthday party, just look at pretend play. They'll do a lot of different social interactions like peekaboo, or trying to get the child to give a social smile or to look at something we're pointing at, to really look at a lot of those different social and communication delays, as well as give opportunity to see any of that more unusual behavior. And then the psychometrician will be taking detailed notes on what they see, which allows them to score up the child on an algorithm that looks for those different symptoms. And so that gives us basically a classification of autism or no autism. And so that's one diagnostic piece that we look at. And that first day, a speech therapist will also complete an evaluation, usually using the PLS, which basically looks at both receptive and expressive language skills. And then our medical provider will complete a brief physical. Now, if we have more than one caregiver present, we can do things simultaneously. So we typically do the interview with one parent while the other parent accompanies the child for testing. Typically with our younger kids, a parent's going to be present for testing for the majority of it, just because we wouldn't expect most younger kids to be separating from parents. Some kids are fine with separating. For the ADOS, we need a parent present, but some kids may be able to separate for the speech testing. So especially if we only have one parent present, that can be nice to get that interview started, just to try to get things going as quickly as possible, just because it can be a long day when we have to do things back to back. So once that part of that day one assessment is completed, so the ADOS and the speech, as well as the interview, the team will get to conference together to discuss initial results and whether or not we feel confident in making a diagnosis that day or whether we want to defer till the whole assessment is completed. So for many of our kids, we can give the at least initial diagnosis of autism or rule that diagnosis out that first day. So if that is the case, we will share those results with the family. And the reason we want to do that is we often find that it's helpful to give families time to process that diagnosis. So since it's over multiple sessions, if they get the diagnosis that first day, they have oftentimes to think about that, kind of sit with it, think about questions. And so when they come in for that second day of assessment and then that final feedback, they're more along in that process of accepting that diagnosis, as well as kind of more ready to talk about what to do next. So if possible, we like to give the diagnosis that first day. If we're not sure, that we will defer. We don't want to give a diagnosis before we really feel confident that that's the correct diagnosis to make. And so what we mean by defer is we're going to wait until we finish that second day of assessment, plus get all those parent forms back before we talk with family about diagnosis on the feedback day. We'll also make some initial recommendations that day. So if families aren't connected with Help Me Grow, we'd be giving them the contact information to do that. We'll also be referring them for speech and occupational therapy if necessary, audiology if they've not had a hearing test yet, and then we may be referring for genetics. So for our kids, we are going to be giving an autism diagnosis, or we are seeing pretty significant developmental delays. Most of them will be referring for some initial genetic testing to see if there's any genetic component.
Christine, This is Di. Interesting that you bring that up, because we just have a question about many of the families that Sarah is working with wonder what genetic counseling, whether or not that would help them, and also why they would do it. So apparently that's
an excellent question.
Yes, and timely.
Yes. Yeah. Yes. So on that first day that we meet with families, the genetic counselor's job is to really go through and get a really detailed family history, both for mental health problems as well as any other physical problems. And what that helps us know is what types of genetic tests might be most helpful. So we have kind of a basic set of tests, and then there's more in-depth tests if they hear specific either family history or symptoms that might warrant those. And then they're also going to explain those initial genetic tests that we'd be running. And basically with genetic tests, what we're doing is looking to see, can we find anything that's abnormal about the genetic makeup that might explain these symptoms of autism we're seeing, or the developmental delays that we're seeing. So the main reason is just to kind of help with cause. Right now we know there's a couple hundred genes that are associated with autism. The difficulty with that is that it's different patterns for different kids, and not all children with autism have these genetic changes, and not all people who have these genetic changes end up with autism. So genetics is really an area where we're still doing a lot of research and trying to understand what we're seeing. But in about 20% of kids, we find a genetic change that would really point to this is what's causing these symptoms of autism. So one thing that can help with is understanding risk for passing that genetic change down. So once we find a genetic change in a child, we'd likely be referring parents for genetic testing to see if it was a change that was passed down through heredity, or whether it was something that changed while the child was developing. So something that changed within their genetic makeup. And that helps us counsel parents as far as what's your risk of passing this to another child if they were going to be having other children. It also gives us a way of helping the children themselves understand when they're older what their own risk of passing these traits down to another child would be. The other thing genetic testing really can help us with is that most genes don't just do one thing. So they're often responsible for many different body processes. And so if we see a genetic change, it may alert us to other medical issues that we should be screening for. So some of these genes are also related to different types of cancer or heart conditions that we'd want to be making sure we're monitoring for if we see those genetic changes. So I'm not sure if that answered your question, or if you have additional questions.
Sarah, just let us, yes, she said yes, thank you.
Okay, good. And so the two initial tests that they typically refer for is a microarray, which is going to look at a broad range of diagnostic concerns that are often associated with autism, and then testing called Fragile X testing, because Fragile X is the most common genetic cause for autism symptoms. So those would be the first two they'd recommend, and then they may, once those results are back, they may recommend further testing if those results don't come back positive, or sometimes that's kind of it for now with the knowledge that we have.
We have a follow-up
And so at the end
question.
of that, yeah.
Sorry, from Betty at Nationwide Children's. How long does it take to get the genetic results, and will they get them back by that second appointment?
That is an excellent question, and the answer is no. They will not get them back by the second appointment. And the main reason for that is actually we need to get insurance pre-authorization before we do the genetic testing, because genetic testing is very expensive. And most insurances, even Medicaid, want to make sure that we have a pre-authorization before they actually draw the blood. And so that unfortunately can take up to 6 weeks. So insurance companies have 6 weeks to give us an answer. Most of the time the testing gets approved, it just has to go through that process first. And so what we do is we start that pre-authorization process if the family is interested in genetic testing that day, and then the family will get a call that says, your testing's been approved, you can go get blood drawn. And so families don't have to make an appointment for that. They can go to any of the lab locations within Nationwide, which we have quite many of them, including some in places outside of Columbus, where families go get that blood drawn. And then after that, it can take about another 6 weeks, up to 6 weeks, to get those results back. So it is a long process. Once those results come back, families will either get a letter in the mail that says testing was negative, meaning they didn't find anything, or they may get a phone call that says that. If something was found, they will get a phone call from a genetic counselor to either talk through the results on the phone or set up an appointment for families to come back in for further genetic counseling to review what those results mean and what additional testing or evaluation might be recommended based on those.
Might be a good time to talk about giving a diagnosis of autism to a child that comes in that may have a genetic condition or something else going on. Like, can they get a diagnosis of autism if they have other conditions happening?
Yes. So autism is a kind of a tricky diagnosis because it's often considered part medical and part behavioral health, but it really is still a description of symptoms, meaning that if these certain behaviors are present, then we would call this collection of behaviors autism, whether that the cause of that is a genetic or medical condition, or whether it's something that we aren't able to yet explain where that cause is coming from. So it is very possible for children to have a range of different genetic problems and also have a diagnosis of autism, as well as other medical problems. So children with cerebral palsy, epilepsy, as we mentioned earlier, children who have been born prematurely and they have other medical conditions related to that. Many of those children may also end up with an autism diagnosis. So after that first visit is done, we give families a summary of that, as well as some behavior forms that we have them return that second day they come in. And then that second day of testing occurs 1 week after, and typically takes about 1 to 2 hours for young children. For that, we're really looking, as I said, at those developmental skills, so kind of the skills you need to learn most effectively. So we either do typically a Mullen or a Bailey, and both of those are looking at different sets of skills. So they both look at early cognitive or early problem solving skills. So things like matching, doing puzzles, finding things that are hidden. They also look at fine motor skills. So things like scribbling, stacking blocks, putting coins in a bank. And then both of them also tend to look at receptive and expressive language. So, what's the child understanding? What do they communicate? If we have a child who's higher functioning, meaning that we aren't seeing as many developmental delays along with those symptoms of autism, we may do a different cognitive measure that's a little bit more higher functioning. So basically what you think of as a more traditional IQ measure. We have one that goes down to 2.5 or 2. And then we also have a measure that's completely nonverbal that starts at 3 years old that allows us to test those cognitive or early problem solving abilities without any words whatsoever. So we do that with the child. So usually that'll be the psychometrician doing that part of the testing with the child while the psychologist is meeting with family to discuss any initial questions, review those parent forms, and schedule a feedback session, as well as supervise the testing that is going on. And then those are some of the behavior forms we give. So we typically give some sort of adaptive measure, looking at how the child's functioning within their home environment. We look at autism symptoms, as well as give families a developmental profile that's pretty similar to the Mullen and Bailey, just because a lot of times within the assessment, we don't get to see everything the child can do. So this gives parents a chance to be able to report what they're also seeing at home. And then we also do a more general behavior measure like the child behavior checklist, which gives us, what other types of behavioral problems might be going on for this child that we want to address. And then once that's all done, we'll have one last feedback session with the family, and that's typically going to be 2 to 4 weeks later. Typically lasts about an hour to an hour and a half, and really that's to go over the final report. So we'll review all the results that we haven't yet shared with family. We'll give final diagnostic impressions, and then really the majority of that visit is going to be spent on what to do next. So we'll discuss all the different recommendations from all the different team members, as well as discuss all the family's choices for interventions. After we discuss with the family what they want to do next, we'll make additional referrals as needed. So we may refer to services within the hospital like CASD. We may direct the family to outside services depending on where they're located. We'll make referrals for things like speech therapy, help me grow if the child's not yet connected. Christine will be talking a little bit more about some of these later as well. And then we'll also discuss whether care coordination is appropriate. So care coordination is a service we provide here where families can come back about a couple weeks after this final feedback session, just because a lot of our families feel very overwhelmed at the end of this feedback session. We're giving a lot of information. Yes, we're giving them that report, but even that can feel overwhelming to look back over. And so what we found can be helpful for many families is to come back in and meet with one of our care coordinators, which are our social work and licensed marriage and family therapist team, to basically review those results again, or review the recommendations, to answer any other questions family has, or even to help with any barriers that families run up with while trying to connect with some of these different services. So our care coordinators will call with families if that's needed, or help problem solve with families and what kinds of things might be barriers to them connecting with these different services, and figure out how to get around those. So for a lot of our families, that can be a helpful appointment, although we leave that up to the family. So we always give it as an option, and then families choose whether that's something they'd be interested in doing. Families will get a lot of copies of the report to be able to give to others as needed. We'll also send one over to the pediatrician. And then families can also meet with one of our autism resource coordinators. So they are part of the CASD side of our center here, and they will come in to talk more in depth about the services that CASD can provide, as well as they are great resources for other autism treatment providers within different communities in the Ohio area. And then we also, so this is kind of a new service that I'm currently piloting just because this is my main area of interest. We're looking at doing more targeted autism developmental assessments, which I'm calling TDAs. And basically what we're finding is that we do have a group of children coming in, kind of between that 18-month and 3-year-old area that are showing pretty clear signs of autism and are often pretty connected with services already. So often have speech evaluations or are connected with Help Me Grow and don't necessarily need that full team evaluation to make an accurate diagnosis. And so ideally, all children would be able to get that full multidisciplinary diagnosis or evaluation. But due to waitlist issues, we're trying to find other ways that we can get particularly these very young children identified and connected with services as quickly as possible. So this is one idea that we're piloting right now, where children would come in instead of 2 assessment appointments, they'd come in for just 1 assessment appointment with a psychology member. So that would typically be me or one of the trainees that I'm working with. And then that person would do the interview while the psychometrician is doing the Mullen and then the ADOS. And then if possible, I give the initial feedback about whether or not it's an autism diagnosis that day. But I still have families come back in about 2 weeks later to do a feedback where we'll talk through, same as the IDA, final diagnostic impressions and recommendations. And so this allows us to pull those kids off the wait list and get them through this diagnostic process much sooner, as well as just kind of free up those larger assessment appointments for kids that might be a little more tricky or need a longer testing battery done. And so right now our DI clinicians are helping make that decision on whether a child would be more appropriate for an IDA or a more targeted evaluation. And then I just want to touch on that the CDC also has outpatient behavioral intervention services as well as just diagnosis. So we tend to see kids that aren't diagnosed with autism for many of our clinics, although we do see some children with autism, especially for our feeding clinic. But basically what we're responsible for is providing behavioral treatment and intervention for a range of different developmental disabilities besides autism. Since we have CASD that does an excellent job of providing a range of services for children with autism, we also have those kids that have more of a global developmental delay or other developmental issues like an intellectual disability that also need behavioral intervention. And so that's what we do as well. There's also additional CDC services, including speech therapy and ongoing medication management that we provide as well. And just to review, to refer to CDC, unfortunately, I was just looking at this today, and it looks like for the online referral, it needs to be a physician or a medical provider. But as I said, you can help families connect with their pediatrician or talk with their pediatrician about making that online referral, or just have families call us. So call the intake line. You can call with them to be able to go through those initial concerns on the phone and get connected with the appropriate place throughout the hospital, which if the concern is autism is typically going to be to the CDC first. So,
okay, so I know, there's several people on this webinar here. Not everybody lives in the Central Ohio area. So there's lots of other places in Ohio to get a diagnosis. So I did list some of those here. So Akron Children's, Cleveland Clinic, Cincinnati Children's, ProMedica in Toledo, Dayton Children's, and the ADEP program, which is started and meant to reach some of the more rural areas that don't have easy access to some of these other major hospitals. So I put the links for all those up there. The main point being that a good diagnosis starts with a developmental screening, whether through the pediatrician and a DI here, some sort of a screening, and then a more comprehensive evaluation. So including a medical aspect, so the developmental behavioral pediatrician, a neurologist, psychiatrist, a registered nurse. So some medical component, speech component, psychiatry, psychology component to it. Having those pieces for a more comprehensive evaluation is important. And all of these hospitals and programs here do provide that type of evaluation. So as Help Me Grow and early intervention providers, how can you help during this process? So first, I make sure the family has copies of their IFSP and any other documentation, evaluations, reports, anything else that would be helpful for them to give to the evaluators. So when they're coming in for their screening or for their diagnostic appointment, that they've got copies of everything that they need. You're welcome to come to the appointments with the family if the family wants you to, especially to the feedback session. Lots of times the service providers do come with the families to those feedbacks to help support them. And at that feedback, you can take notes for the family to refer to later on. You can make a list of next steps that need to be followed up on as the recommendations are being talked about. It is really overwhelming for the families. They're not going to take everything in and remember everything. So to have someone there writing some notes down for them, helping make a list, and helping kind of focus them on what the next steps to take are is very important. Then you'll be giving families, it's very helpful for you to be able to provide them with accurate information and resources about treatment providers in your area, funding options for services, things like that. So making sure that you have accurate information about the funding and about the treatments. So as families ask questions, you can answer those accurately. And then to support the family in whatever treatment path they choose. So if the family wants to go do one sort of treatment, that's, to support them and help them get connected with those resources. If they decide not to do anything at all, to support them in that path. If they do want to start services, to connect them with and collaborate with the service providers as soon as possible in order to prevent delays in starting services. So if they want speech or additional speech services and need to add those to the IFSP, or they want to start ABA, or they want to start Play Project, whatever it is that they decide they want to do, helping them get that onto their service plan and get those providers added. And then if a lot of times service coordinators are new, or it's a new situation, things they haven't done before. So involving your supervisor, involving DODD staff, if you're unsure of some of the information about funding, about the IFSP process, things like that. So making sure to check with your supervisor, so that again, you're giving the families kind of the most up-to-date information and helping them get connected with what they need.
And so as far as things that you can tell the family about the diagnostic process that might help clarify things, the biggest one being that this is going to be a multi-step process. So a thorough evaluation is going to take more than one appointment. And again, the DI is not an evaluation. Families will not get a diagnosis at that appointment. And the goal of that is just really to make sure kids get to the right place. And the reason that this is a multi-step process is that this sometimes can be a very straightforward diagnosis, but many times we need to see the child multiple times to really give us a full view of that child, as well as collect all of this additional information. At this age, many times I'm not making a diagnosis. So even when they get through the whole diagnostic process, I think it can be helpful to tell families that if we're not sure, we won't make a diagnosis. We'll often defer the diagnosis, have families wait 6 months, do some additional intervention, and then come back in and see us. So we don't want to make pretty significant diagnosis until we're confident that that's what fits that child best. The other thing that you can help with families is making sure they have all their evaluation reports ready. So both those completed through Help Me Grow, as well as any outside evaluations, as this really helps us determine whether a family is appropriate for a targeted evaluation, or whether they need that more comprehensive evaluation because they haven't yet been connected with speech and other medical providers. The other thing that you can do is really encourage families to ask questions and voice concerns. We are not offended by families disagreeing with us. And I'd much prefer a family to tell me when they aren't comfortable with something, or something doesn't make sense to them, or they need more clarification or information, or even when they just completely disagree with me, because then we can have a dialogue about that rather than leaving unhappy. Not going to be able to make everyone happy in the end, but at least it gives us an opportunity to discuss more what the concerns are, as well as to clear up any misinformation or give more information as needed.
Autism Speaks, I put the link on here, has a very nice thing on their website about 5 things that families can do while they're waiting for an autism evaluation. So this is often nice to share with families. So the first thing is they can be learning more about autism. So there's a 100-day toolkit, and there's a 100-day toolkit specifically for young children. So families can start looking through that and kind of, starting on some of those first steps. And on the Autism Speaks website, there's also a nice handout on what is autism, kind of explaining autism. So the families can be kind of doing some research, learning a little bit more. They can be gathering all the reports and documentation. They can be learning about what to expect at the evaluation and what's going to happen, what their child's going to need to do, how long it's going to take, how many appointments, kind of learning everything. The family can arrange for support. So they want to have somebody come to the appointment with them, another family member, their service coordinator, but arranging, they can be getting someone that can be there to help support them. And they can be getting the ball rolling on intervention, because most of the services have wait lists. So while they're waiting for the evaluation to happen, they can go ahead and start getting on a wait list for speech or for Help Me Grow if they haven't yet, or any of the other areas that they need to get connected with, just to save some time.
So things could help if a family is hesitant about coming in for an evaluation. A lot of times it can help just to give them more information about autism spectrum disorder. So that Kennedy-Krieger video can really be a great tool for parents, especially if you're getting kind of that, well, he's only 2, how can you know? Or, 2-year-olds do kind of weird things, and they do. But it's when we see that pattern that is most concerning. And so I think the Kennedy-Krieger video, unfortunately, you guys didn't get to see it, but go look at it because it's a great video for showing those differences between kind of typical play in children versus play that might indicate something more is going on, like autism. Autism Speaks also has a Learn the Signs checklist that families can go through that gives more information about what things to be concerned about. You can also have a family complete the MCHAT online. So the MCHAT is a free measure. The scoring is also online, so you can score it up for the family, especially if for some reason the pediatrician isn't doing this at 18 months. You can help the family do that to help understand if they need a referral or not. And then there's a Screen Your Child link through Autism Speak that can also help with that process. The other thing, as I was saying before, is help the family understand that this is a slow process because we're trying to be hesitant with a diagnosis. We don't want to just slap a diagnosis on every kid that comes in. Families are often concerned that once they're referred, that automatically means their child's going to be getting a diagnosis, and that is definitely not the case. We will defer if need be to, as I said, give the child a little bit more time while doing some interventions if it really is unclear at this time. And then the other piece to this is explaining the importance of early intervention. So a lot of families will want to take a wait and see approach where it's like, well, let's give him 6 more months or let's give him 12 more months. And the difficulty with that is that we're missing time that we could be doing some early intervention. And the other difficulty is with waitlisting, as long as they are waiting 6 months and then coming in for an evaluation might mean you're actually going to be waiting a year to get through that whole evaluation process. And so the sooner we can get families at least in for some of screening can be really help us save time. And then I think the other thing to really stress with family is that the biggest concern with identifying autism is that with especially in our younger kids, when autism is apparent, those symptoms are affecting the child's ability to learn. So they are starting to put that child behind in different learning areas and development. And the sooner we can start intervention, the better we are at lessening the impact of those autism symptoms on learning. And brains are just more flexible when we're young, so the sooner we can start these things, the better responses we tend to get.
So O'Calley has a nice handout too that you can look at. It's called Sharing Concerns. So if you suspect a developmental delay or autism, speak up. This is nice for family members. Sorry. This is very nice for family members or caregivers, it is a nice description about how to talk with families. So if a grandparent, an aunt, speech therapist, if somebody has a concern about a child, how do you talk to the family about that? So these are some of the points that they list. So set the stage for a successful conversation, get into the right environment, make sure it's a good time, that you've got some privacy, the parent can kind of sit and focus. Start at where the parent is and with what their concerns are, and then you can kind of go from there. So they may only be concerned about the speech at this point, and they may not be ready to see or talk about the other things, but you can kind of start with where they are and ask them what their concerns are and what they're worrying about. Be supportive, not kind of judging them. Focus on what the child's doing well, and the need to kind of rule out anything that's more serious. Referring the parents to other resources. So sometimes parents just do need to come to this on their own. They need to see the videos, they need to read stuff on the website, they need to kind of do it on their own. So giving them some information, some books to read, things like that can be helpful. Emphasizing the importance of early intervention, identification, and how critical that is. Remembering that sharing your concerns is the right thing to do. It's hard, and the families may not like it at the point that you do it. It may be hard for them to hear, but the most important thing is just getting started with the conversation. And then knowing that by sharing your concerns, you actually often are validating what a parent's not been able to express yet. They may be fearing, and they may be afraid of, or maybe not be unable to express it. And by you starting the conversation, it's actually validating things that maybe they haven't brought up yet. So this was a very good handout to look at from O'Callaghan. Also, there's some things not to do. So don't dismiss a parent's concerns and tell them that, oh, boys talk later, or all kids do that, or da 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 da. So a lot of times parents, it's important not to dismiss their concerns, not comparing one child to another, not using labels or technical jargon, and not scaring them, keeping it positive. So remembering that no harm can be done by reminding the parent that no harm can be done by checking out their concerns. If the concerns are ruled out, then the parent can feel a lot better. But if the concerns are confirmed, then the parent can be getting help and the child can be getting back on a better developmental path. So either way, it's the right thing to do. Either they're gonna be able to not worry as much and know that things are okay, or they're going to be able to get the help that they need. So if you're not sure what to say at all, if you're worried that any mention of autism is going to scare the family away from going to just the screening, you don't have to mention autism. That's why we wanted to point out that the CDC is really about neurodevelopmental delays of all sorts. And so you can explain that you're just referring on for more specialized developmental screening because of the motor delays or the speech delays. You don't have to bring up autism. And so because the DI clinicians here do have a lot of experience kind of breaking that to the families and talking to the families about that. You can refer the families back to their care coordinator, or you can have them call one of the resource coordinators here. So they can meet with a social worker, or meet with a counselor, meet with a resource coordinator here, and have their questions answered maybe before they come in for the appointment. So that, I think, talks a lot about the diagnosis and about your role and how you can help. I did want to just briefly talk about the treatment, since what will happen is after the diagnosis, a lot of families will be referred on for treatment assessment. So I wanted to talk a little bit about that. So my program it's a CASD, Center for Autism Spectrum Disorders. This is just a grid laying out all the different types of services we have here: toddlers, school age, transitions, parent training, counseling, social skills groups, all severe behavior, day treatment, all kinds of things that we do here. So usually kids are referred to us for treatment by the CDC following a diagnosis, or maybe by another children's hospital provider that's been working with the child. So we get the referral internally, or the primary care provider submits the referral for treatment services. Or sometimes the families do call in independently and they speak to autism resource coordinator and they request an intake. We do have some families where their pediatrician doesn't agree with autism, doesn't think the child has autism, so he won't refer the child in for evaluation or something. So families call on their own. So once a referral is made, the family's called to assess their interest in treatment. Say, okay, we got this referral from the CDC, or we got this referral from your pediatrician or your speech therapist. Are you interested in coming in and having an appointment to talk about intervention and services? So if they are, then the paperwork is mailed to them, they fill it out. Once they return it, then the intake appointment scheduled with the clinician or psychologist from the right program. So depending on the child's age and the concerns that are being reported, they might go to transition program or to the school age program, or they might come to my program, which is a toddler program. So I do all the early intervention, like the very early intervention under 6, but primarily I'm working with the kids that are under 3. So our wait time right now for an intake for treatment for the toddler program is within 8 weeks, and right now we're like less than 4 weeks. So we have specifically streamlined this process so that we can get kids in less than 8 weeks and get them started in treatment. So we have worked very hard to streamline our wait list and get these appointments in, so that we know that families at this age are working against deadlines, and everybody is telling them the earlier the better, and you've got to get started. And so we don't want to have them have to wait 6 months to come in and talk about services. So we get them in. These kids that are under 3.5, we get them in fast. So the treatment intake appointment, basically that's a 2-hour appointment in Westerville. And by the time they come here, families are like, I thought I was starting services. How come I have to have another appointment? So we often explain several times that this is to talk about, again, to get them basically started with their treatment services. So again, we do go through, get updated clinical information, because some of our families have not had anything updated in a while. So we do about 75 minutes or so of going through what the parents' concerns are, what the current services are, school placement, things like that. And then we spend about another 45 minutes going through individualized service options. So based on, again, the child's profile, their age, family location, all kinds of things, saying, okay, here are some things that we would recommend for you. So with that, we talk about funding for those services. We talk about timelines for getting started, referrals that they might need to other providers, and any recommendations that we would make. And then after that, a follow-up phone call is usually made within the week to determine basically if the family has any other questions, or just to verify that they want to proceed and that they're working on the next steps. So as a range of treatment options, these are some of the things that we offer that we talk to families about. So there's our toddler program for the 3 and under. There's traditional ABA for the ages 3 to 8. We have school age for ages 8 to 12, transition age for 12 to 21, behavior, just general behavior consultation, school consultation, where we contract with different school districts, outpatient psychotherapy, so counseling and cognitive behavior therapy for kids that are 8 to 21, social skills groups for kids age 8 to 18. We also do have some play groups for the 5 to 8-year-olds. We have 2 different play groups now that are going on. We have autism caregiver training, which is a 12-week parent session, 12 weeks of parent sessions, one-on-one. Some parenting group classes that we offer. So parenting your child with autism and triple P. We have SIP shops, which are monthly workshops for brothers and sisters, ages 6 to 12. We have Autism Academy lecture series, which is a once a month lecture on a different topic related to autism. It could be medications, IEPs, toilet training, feeding, summer programming. They go throughout the year, they go through a range of different topics. And families can come in if it's a topic that they think relates to them. And then we do have the ARCs connect them with resources if they don't live locally. So if they need to find a speech therapist in their area, or they're looking for something closer, the resource coordinators do follow up on that.
A 2-minute warning. 2 minutes left.
So I do know that those are often the range of recommendations and options that we talk to families about, and then they can choose which they think is going to be best for their child and their family and their schedules. Just as some quick information for our toddler program, in 2018, so far we've gotten 128 referrals. Out of that, 96 families wanted to schedule a TA, and I think maybe 85 of those actually showed up for the TA. Out of those 85, 20 started in intensive services, and then 17 started in intensive services, and then 20 just got some parent training services. So out of those 128 referrals, we really only ended up providing services to 37 of those kids. So many of the families decide to not go, they choose other services, they do center-based programs, they choose not to do anything. So, we truly let the families choose. We give them their options, and then we let them kind of decide what how they want to proceed.
We have a question.
Sure.
So
that was it. So it's a perfect time for questions.
Okay. Are you a BCMH provider, and is the testing covered under the diagnostic piece of BCMH?
So we have some medical providers that are BCMH providers, and so that's only for the interdisciplinary diagnostic assessment, so that full IDA. And unfortunately, nurse practitioners can't be BCMH providers at this time, and so any of our IDAs, which is a good portion right now, that have nurse practitioners as the medical provider can't do BCMH, but we do have some developmental pediatricians. And so what we do is we try to get families scheduled in those slots for the BCMH providers when we think that that's going to be a necessary funding option to help cover that diagnostic piece of it. So there's no autism treatment, unfortunately, isn't covered by BCMH, but the diagnostic process can be if we can get them into that right appointment. So we do encourage families that think they're going to need that funding source to try to talk about that at the DI, so we can make sure to get them scheduled with a clinician who would be able to use that.
And that'd be a very important conversation for our service coordinators or interventionists to have with the family as well then, too. Okay, well, Drs. Christine and Elizabeth, this was a very worthwhile Doughnuts with Di. We've already received quite a number of comments about how much the participants participating this morning has enjoyed the presentation. We have comments like phenomenal presentation. They really appreciated the links to some handouts and worthwhile presentation. We're getting those all over the place here. So already the feedback is very positive. So on behalf of early intervention, I want to thank you for approaching us. So I think it's important for everyone to know that you approached us wanting to contribute your expertise and knowledge to our field to help families at a time that can be very scary. And for some of us, this process is about to become real. So, on a personal level, I really think this will really help me support my son and his wife in their adventure. This is very, very helpful. And in turn, we will be able to help many families understand what can be a very scary and frightening thought about, the process. And so the more information we have, the better. So thank you.
So feel free to contact us with any questions. We'd be more than happy to do another talk on a different topic at some point. If you want us to come back and talk on some other, on another topic, we'd be happy to do presentations as well.
And so anyone who's participating today, if you can think of a topic that you would be interested in or that Doctors Christine and Liz could help us with, please let us know and we'll reach out to them. Again, I cannot thank you both enough for taking the time and doing this. I learned a lot, and clearly the participants learned a lot too. Thank you so much.